This is Still Done Now with Mario Nass. Envisioned by the people, voiced by the people, powered by the people, it is everyday people with extraordinary values that make up the New Right Network. Welcome to the healthcare voice of New Right Network. This is Stealth on Health, and I'm Mario Nasinovich. Joining me for our episode is Daniel Gruener, MD, Chief Medical Officer of Evolution Research Group, LLC, known as ERG. Dr. Gruener is highly respected research investigator, a psychiatrist, and industry-leading expert in psychiatry, pain, addiction, diabetes, and HAL. He joined ERG in 2015 as medical director of the St. Louis Clinical Trials and vice president of clinical and scientific affairs. He leads a large medical team across all sites at ERG. Dr. Gruener has participated in over 400 early and late phase clinical trials. He's a past board member of the American Pain Society and author of numerous publications. Dr. Gruener is board certified by the American Academy of Pain Management and the American Board of Psychiatry and Neurology. He received his training at Thomas Jefferson University Hospital in Philadelphia. He served on the faculty of Jefferson Medical College and subsequently the University of Pennsylvania for many years. I've recently had the opportunity to meet him virtually and collaborate with him, and now I get to welcome him to the 6th episode of Stealth on Health. Dr. Gruener, welcome to the show.
Thank you, Mario. It's a real pleasure to be here. I have to apologize for my hair. I look like a throwback to the 60s, but of course, I can't find anybody to cut my hair, and I always wonder where these people on television are getting their haircuts, in this era. So if anybody can give me a tip, I'd appreciate it, because I'm not going to cut my own.
I dared to try to cut my own, and then my wife said, you know what, let me take care of that. So we headed out onto the deck, she hit the buzzers, and we were good to go. So you may want to employ some helpful hints at the home base.
My wife refused. I'm not going to push it.
Excellent. So, Dr. Gruener, we know that each year millions of Americans face the reality of living with mental illness. And each year during the month of May, we have a national movement to raise awareness about mental health. How important is it that we continue to address the stigma, provide support, educate the public, and advocate for policies that support people with mental illness and their families?
It's critically important now more than ever. So May is Mental Health Awareness Month. This is an initiative supported by NAMI, the National Alliance for the Mentally Ill. And the purpose is to destigmatize mental illness and to raise awareness. But I think that really takes on a lot more meaning this year because of the pandemic. And the message from NAMI, the theme for Mental Health Awareness Month this year is "You are not alone," which really resonates because everybody is isolated. People with mental illness, some of the symptoms are social isolation and fear of being alone and abandonment. So this is really tying into a lot of their fears and really making mental health issues more prevalent and more worse. But you don't really hear much about it. It's not getting the attention that it deserves. Mental health is as important as physical health.
Most definitely, and I think we're really standing on the shoreline, and we're seeing those waves that are way out there right now that are going to be upon us very, very quickly. And while we were not adequately prepared for the pandemic, I think the onslaught of mental illness and serious mental illness that's just awaiting us. We really need to take some time and make some preparations. But nowhere better than the month of May to do that. And I appreciate your opening comments because certainly these are unprecedented times and could not be a more appropriate time for us to kick off this national conversation to raise awareness. But there are some terms specifically that I just used, like serious mental illness and mental illness in general and mental health disorders. And they may all seem like they're referring to the same thing for most of our viewers, but in fact, they refer to specific diagnostic groups for a particular study or for a particular group of people. Can you address each one of these terms and how we should define them and how we should use them correctly going forward?
Sure. So we all have mental health, right? And hopefully our mental health is adequate. I think it's fair to say that virtually nobody has adequate mental health with what's going on.
Not at the
But
moment.
I look at it, right, exactly. I look at it as a continuum. So many of us are stressed, we're anxious, but we're functioning, and we can deal with it, and we can adapt. But for some people, it could be people with a pre-existing mental health disorder, or someone who perhaps has not had a pre-existing condition, but just sort of snapped under the stress of what's happening. So when people start developing symptoms like difficulty with sleep, it could be trouble falling asleep at night, it could be sleeping too much, appetite disturbance, especially when there's weight loss involved, decreased ability to get pleasure out of things that are normally pleasurable, low energy, severe fatigue. We then start getting into the realm of mental illness, things like major depression, major depressive disorder. And we then need to look at people's ability to function. So you can have a mental illness, but still be able to function, work, take care of your children, take care of the house, hopefully pay your bills if you can afford to do that these days.
Well, certainly.
But when you reach a point where you can't function, we start to cross the line into serious mental illness. Although usually serious mental illness is associated with disorders like schizophrenia and bipolar disorder, which is commonly referred to as manic depression. Those are two of the most serious psychiatric illnesses, and actually are associated with the highest rates of suicide.
And we'll talk about all of this and so much more. But I want to start off by talking about the clinical evaluation. And we just started talking about some of the signs and the symptomatology. You mentioned some of the more common mental illnesses and certainly some of the more serious mental illnesses. But when we're talking about the clinical evaluation of an array of signs and reports of subjective experience in order to establish diagnosis, how important is care and thoroughness for a differential diagnosis? And how does this differ, if at all, from one clinical setting to another, or from clinical practice to clinical research in your vast experience?
Well, first of all, the evaluation is extremely important, and I would hope would be very thorough. So psychiatrists are medical doctors that have specialized training in mental health disorders. So we use something called the DSM, the Diagnostic Statistical Manual. We're up to the 5th edition of it. And this is a manual that categorizes mental illness. And the purpose is such that if 5 psychiatrists evaluate the same patient, we'll come up with 5 similar or the same diagnoses. So it provides consistency, across the realm of diagnosis. So how do we evaluate people? We talk to them, which is why we're going to talk about virtual visits and telemedicine and telepsychiatry. Very timely to talk about that now. So most of medicine involves talking. Most of medicine, 2/3 of what can be done via telemedicine. There are things that need to be done in person, like most aspects of the physical. As I mentioned, psychiatrists are medical doctors, so we evaluate the physical well-being of a person as well. So we do physical exams. We do things like blood work and electrocardiograms. But we also talk to people. We get a very thorough history. We evaluate what symptoms are currently experiencing. We do what's called a mental status exam, which is the psychiatric equivalent of a physical exam. And then we put that together and come up with a differential diagnosis, which we then list by order of the most likely possibility. And as a result of that, we then come up with a highly individualized treatment plan. The problem right now is that people do not have very good access to these types of evaluations. It's really never been good. There has not been adequate access to psychiatrists and other mental health workers for quite some time. It's now worse than ever. And people suffer in silence. They're ashamed to talk about it. They're afraid to talk about it. They may be so isolated they don't know who to turn to, and they stay at home isolating more and more. So we need to bring people out of the shadows and let everyone know this is okay. It's nothing to be ashamed of. It's just as important as physical illness. And you need to talk to someone. National Alliance for the Mentally Ill has a website. There's an 800 number. You can call them and find out resources in your community. There is help available, but if you don't ask, you won't get access to it.
Agree. And we know that the DSM, as you said, allows to create better objective measures so that the evaluation and the diagnostic process can be the same regardless of who may be evaluating that patient. Does it differ at all from that clinical setting to maybe clinical practice, clinical research? Does it differ at all depending on where the setting may be on how that person's evaluated?
Absolutely. I think that's a good point. The setting has to be taken into account. So the ideal would be to evaluate someone in person, because if someone feels isolated, think about what it's like to be interviewed over the phone or even by
via Zoom.
Exactly, right. And that's how a lot of these evaluations are being done. So I think it's very important to realize the limitations and to acknowledge that with your patient or client, as the case may be, and let them know that this may not be ideal, but it's certainly a good alternative. And it's okay to be uncomfortable, and there may be more time forming what we call the therapeutic alliance. But it's a good form of treatment, and it gives access to people that wouldn't otherwise have access. So it's very valuable, and we're fortunate that we have the technology in place already.
Excellent, excellent. And we will talk much more about that technology shortly. But let's take a pause here for our viewers who do not know the depth and breadth of how big these issues are. Let's get inside the numbers a little bit, because these are certainly eye-opening statistics. And let's start off with perhaps the biggest number. How many U.S. adults experience mental illness each year?
So it's estimated that 1 in 5 adults experience mental illness. To put that into an actual figure, 40 million Americans suffer from mental illness, but it's estimated that during times of crisis and times of extreme stress, that figure doubles. So it's likely that there are 80 million people in this country suffering from a mental health disorder or a mental illness at this point in time. I mean, it's a staggering number.
It is. It's almost absolutely overwhelming. And to think about then the individuals who normally experience serious mental illness, some of those advanced disorders that you mentioned in your opening, how many serious mental illnesses do U.S. adults experience on a yearly basis?
It's 1 in 25. It's still very high. I mean, 1% of the population is schizophrenic. So the numbers are still quite high, especially when you consider that serious mental illness carries such extreme risk, most notably suicide.
Right, right. And we will talk a little bit more about suicide in this discussion as well. Switching gears, thinking about the youth of America, those aged 6 to 17, we know that for some of the conditions, it can take a couple of years, sometimes a decade, to be diagnosed. But how many U.S. youth experience mental health disorders each year?
It's very prevalent in adolescents and in children. Often, even severe mental illness will manifest as early as age 10. I've seen kids as young as 4 or 5 develop symptoms of bipolar disorder. And the suicide numbers are very, very high in younger populations as well.
Yeah, and let's jump right into that. We know that suicide is a very complex, multidimensional event, certainly with a host of contributing factors. Can you share with our viewers some of the historic data of this leading cause of death in the U.S.?
Of course. So it is the 10th leading cause of death in general in the U.S. In younger age groups, is the 2nd leading cause of death. And to put it into actual numbers, over 40 million people committed suicide, not attempted, committed suicide in 2008. It's projected that that number will reach 75,000 this year as a result of COVID-19. 75,000. Now, I think that's
So that's
actually
almost double from the 40,000
it,
number.
exactly. I think it is double. I think it's more
Wow.
like 80 to 100,000. And when you look at the projected deaths from COVID-19, there's as many possible suicides as there are from people that will die of the virus.
Wow.
So in a sense, there's a pandemic of suicide as well. And that has to be taken into account when plans are made, to deal with this horrible crisis.
Well, this is certainly not our first pandemic. This is not our first event where we've experienced such tragic loss. But where and when have we witnessed throughout history an increase in mental health disorders? Certainly with the emergence of coronavirus disease, we're now seeing more patients with depression and anxiety. You mentioned that we expect suicides to nearly double. Are there certain events, certain triggers? Tell us a little about what you've read and what you've experienced historically.
So it's interesting. Historically, there seems to be a correlation between economic downturns and suicide. So if you look back to the Great Depression, the numbers of suicides were just staggering. And people committed suicide who had no pre-existing psychiatric symptoms whatsoever. They just couldn't feed their families. They felt hopeless, and it was the only out that they saw for themselves. During other pandemics, this is not the first one. The 2000, we had a pandemic regarding another coronavirus, H1N1. That was the Spanish
2003.
flu.
Yeah, yeah.
Yeah, actually, during the Spanish flu, the suicide rate skyrocketed, and the prevalence of mental illness went up as well. And pretty much every economic downturn, including the recession in 2008, was associated with a spike in both psychiatric illness and associated suicide. So if
Wow.
you look at the potential recession that we're most likely heading into now, it's not surprising that these numbers are projected to be so high. But I do want to make the point, these numbers are projections. It doesn't
Correct.
mean that this is going to happen. So some of these deaths are preventable. Just like, we're utilizing things like social isolation, social distancing to lessen the transmission of COVID-19. There are measures that we could take that could decrease the risk of suicide, but are we taking them? You don't really hear about this.
Agree. And I think this is certainly the right opportunity and the right type of topic that we want to continue to raise awareness and continue to dialogue about. Certainly, I'll be keeping track of those numbers, and maybe as we gather more insights, Dr. Gruener, I can invite you back and we can evaluate that together. Let's talk about the patients, though, that present, those with depression and those with and that have made some type of an attempt on their life. How do you engage these individuals? What are the first steps in terms of their evaluation? And how do you just prevent some of the next steps from occurring?
Well, psychiatrists are notoriously bad at predicting behavior, but we tend to say the best predictor of future behavior is past behavior. So certainly if anyone has ever attempted suicide or if they've thought of suicide, that's a major risk factor. But some people don't have a history and still make attempts. So there's a myth that you don't want to ask people whether or not they're feeling suicidal because you might put the idea in their head. That is not true. If someone is thinking about it, you're not going to drive them to suicide by discussing it. They'll probably be relieved in terms of being asked about it. So it is a must that in every evaluation, we always ask about whether someone is experiencing thoughts of suicide, even passively.
Or
We ask
deliberate
them if
self-harm, for
they
that matter.
don't want to wake up and
Yeah.
exactly.
Yeah.
I used to be an examiner for the American Board of Psychiatry and Neurology, and I would examine candidates for board certification. And if someone forgot to ask about suicidality in their evaluation, it was an automatic fail.
Wow. Wow. Talk a little bit about ideation as well. So there's the actual act in terms of the attempt, but talk a little bit about the ideation.
So people may have a general a thought of suicide, but they haven't thought of a plan or a method that they would use. That's very concerning. What would be more concerning is if someone tells you, I'm thinking of suicide, and I actually went out and I bought a gun last week, and it's under my pillow, and I keep it loaded, so if I get the urge, I'll shoot myself in the head. So something like that is an absolute emergency. I would likely call 911 and get that person hospitalized immediately.
Excellent.
So you want to evaluate potential risk.
And you know what? I didn't plan on asking you this, but I do believe that certainly while we are talking more along the lines of raising awareness, what should a loved one, a friend, a caregiver, a family member do in the case where they hear some of these signs and symptoms expressed by an individual, especially at this time where we're social distancing? Should they call 911 and report that? Better to be safe than sorry?
It's definitely better to be safe than sorry. If there's any suspicion that someone's life is in danger, we have an obligation, especially for a loved one, to report that and get them the help that they need. You could be saving somebody's life, literally.
Absolutely.
They may be angry at you for doing it, but it's better than them ending up dead.
Absolutely. No, and certainly we've got so many complications that we're dealing with right now. I would welcome the opportunity for someone to be angry with me rather than not being able to mourn them at a funeral that I could have prevented. So I think that is a powerful message to share with all of our viewers, that if you do get the sense that someone is experiencing some type of event, some type of feelings, and they have expressed to you some of their thoughts, their ideation, if it's suicide or if it's just depression, anxiety, and I don't want to say just to minimize, but certainly in the grand scheme of things, from suicide to just being a little anxious or being a little depressed, that's a wide range of expressions. I think it certainly behooves us to learn a lot more about this. Resources are available, as Dr. Gruener has shared on the NAMI website, and certainly it's upon all of us to be a good neighbor, to be a good friend, to be a good family member. But in the cases where people are talking about doing some severe action or some deliberate self-harm, or making an attempt or making a plan, if they've got a plan, we need to be able to take those necessary steps and precautions, call 911 and get ahead of it. I want to switch gears somewhat radically in our conversation to talk about something that you do absolutely every day, and that is to participate in research on mental disorders. And really a broad question to start us off here on: when is it appropriate, considering the wide range of patients that we've been talking about, to ask them to participate in research? And what are some of the legal, moral, and perhaps even bioethical concerns that you have to mitigate when you're inviting them to participate in research?
All very important questions, and it's what I now do full time. I spent a big part of my career in private practice and hospital administration, but I now devote the majority of my time to research, which I absolutely love. I think it's one of the most important things you can do. And when is the appropriate time for people to participate? There's always an appropriate time, because it's the only way we're going to make any headway in developing new treatments, not just in mental illness. I mean, my company and I, we do studies in many different therapeutic areas, not just mental health, but other central nervous system disorders, endocrine disorders, like diabetes, addiction, pain, post-operative pain. I mean, I could, NASH, the list goes on and on.
Sure.
We have sites all over the country, and there's specialty sites that concentrate on many different areas. So it behooves everyone to participate, or to think about participating, or else we won't make any gains in finding new treatments, maybe even cures for various diseases. And it's more important than ever. You mentioned there possible downsides to doing clinical trials. Well, there's a difference between treatment and engaging in research trials. So the purpose when we treat patients clinically,
Mm-hmm.
we're trying to get them better.
Right.
And that's the end result. Ironically, in a research trial, that's not the goal. It would be nice if that happens, but it's not what we're looking for. We're testing out a compound, a medication, a treatment, could be a device. And we want to see if that treatment is both effective and safe. Now, we also utilize placebos, which commonly are referred to as sugar pills. They're basically sham treatments.
Mm-hmm.
There's no therapeutic value whatsoever. And the studies are what we call blinded. They're double blinded. So the investigator and the staff doesn't know what the subject is getting. We don't know if they're getting actual medication or a placebo. And the subject themselves also don't know what they're getting. You know, there could be a 50-50 chance that they'll get actual treatment or they'll get a placebo. And if they get actual treatment, remember, we're testing out whether that treatment is effective. So we don't even know if the treatment works. So the purpose of the trial is to determine efficacy, whether a treatment works, and safety. So why should somebody do this? Well, again, if they didn't do it, we wouldn't make any advances.
True.
And remember, when we do clinical trials, we're constantly evaluating the subject. You know, we're trying to be as objective as possible, but we're still clinicians, and we see them frequently. We probably see them much more frequently than they would in a practice situation. It may be weekly. In the case of an inpatient trial, it may be daily. If we see any signs that a person is decompensating, that they're getting worse and they need treatment, we jump on that. You know, we don't just continue the trial. We'll do what's safe. If we need to, we'll remove them from the study and we'll make sure they get treatment. We may even, we may treat them ourselves.
Right.
So, that mitigates a lot of the risk. Now, of course, there's always a risk when you're taking an experimental medicine, but we share that. We have people sign what we call informed consent. It lists every possible risk. We make sure that a subject understands each and every one.
No, I think we've covered a lot of ground there, and certainly we know that there are medications that are available for the alleviation of symptoms, continued investigation into treatments and psychotherapy techniques. You mentioned some of the technologies and devices and how they're used. We've just covered also a lot of ground in terms of how some of these clinical studies are designed. We talked a little bit about placebo control. We also talked a lot about the responsibilities of a primary investigator for what needs to be done if you've got a potential patient that is experiencing some type of crisis. These are just some of the obstacles and challenges when conducting a clinical trial. Any other obstacles or challenges that come to mind in the conduct of high quality clinical trials?
Definitely, but there's one more point I'd like to make. So we talked about how there is not adequate access to treatment right now, but we need subjects for research trials. Mm-hmm. And it's still a form of treatment, taking into account the factors that I've mentioned. You're still being seen by a very experienced physician. You're getting thoroughly evaluated. And a lot of people get a lot of benefit out of being in a clinical study, and it may be the only form of treatment or even contact that they have. So there's a lot of benefits these days with the pandemic going on, I'd say more than ever. So there's very compelling reasons for people to participate in clinical trials. Now, this shouldn't be a reason for someone to participate, but we respect someone giving up their time, and there is some compensation involved. I mean, not enough, so that's the incentive for someone to participate. But with considering what's going on, that's certainly something beneficial for people. So there are a number of good reasons why the time is better than ever for people to participate in clinical trials.
And can you tell a little bit about why the clinical trial continues to be the mainstay of evidence-based medicine, specifically in psychiatry?
Well, psychiatry, it poses particular challenges. When you're studying a medication like a diabetes medication, pretty simple, right? You check people's blood sugar, you give them medicine A,
Yes.
and lo and behold, hey, their blood sugar stabilizes. That's evidence that the medication works. It's not quite that simple in psychiatry. We don't have a blood test to measure whether someone is less depressed. We may someday, but we don't now. So we've had to develop some very complicated scales that require a lot of finesse and a great deal of training that need to be validated, and they need to be administered at nearly every visit. And those are the types of endpoints that we look at to determine whether psychiatric treatments are effective. So it's much more complex than other types of studies.
No, I think that's a great way to summarize it, and certainly we know that the diagnosis that we talked about earlier, the treatment of mental disorders, remains an enormous challenge, and patients certainly are presenting with a wide variety of signs and symptoms, and sometimes a combination of symptoms. And response to treatment and the illness course certainly will vary considerably due to an enormous amount of factors as well. We just briefly touched on it, Dr. Gruener, but let's dig in a little bit. What is currently missing in terms of some of that neuropathological, some of the neurophysiological and neurochemical measures, and what are we hoping to answer in the future? What's currently unanswered, and are there anything that you currently deem that may be unanswerable, regardless of what we may be able to achieve from a scientific or a technological standpoint?
Well, I'd like to think there's nothing unanswerable, but there are a lot of things that we may not get answers for in our lifetime. But I think
Understood.
eventually we will. The brain is still unmapped. We only understand maybe 1% of the brain and its potential. That's why I love psychiatry and,
Sure.
and neurology,
Yeah.
because that's where the brunt of science and medicine, in my opinion, really exists. In terms of unclaimed territory. So we're making a lot of progress. We're mapping out genes. We're developing biomarkers that can help drive appropriate medications. I participated in a study where we actually were able to administer blood tests that helped us decide what antidepressant someone would preferentially respond to based upon their genetic makeup and other factors. And that technology actually exists. So although we've made a lot of strides, there's still a lot of work that needs to be done. Very exciting.
Very exciting indeed. And hopefully there isn't anything that is unanswerable. We may not live to see it, like you said, but hopefully it can be achieved one day, and certainly a lot of amazing people working on certainly a tremendous amount of research in these areas. And certainly understanding a lot more about the brain than we did just a few years ago. Response in many clinical trials is defined by percent improvement over baseline, and certainly is highly dependent on whatever the baseline severity is. We've seen some very amazing and promising compounds fail miserably that haven't reached that level of success in clinical trials recently. But we can all agree on that part. The challenge, I see it, and I wanted to get your thoughts on it, is that the most meaningful response measures should really be the remission of signs and symptoms. And I wanted to ask, why do we not define success as to what is most meaningful to the practicing clinician and to their patients, especially in mental health disorders, where you are able to judge what that physical sign and what is most meaningful to the patient. Maybe the measure on the percentage improvement doesn't match where it needs to match, but you've seen the change. Can you talk a little bit about this?
Well, that's an interesting question. Remission is an ideal. That is complete absence of symptoms. Thinking back, I think I've only participated in a study that achieved remission in one case. I was lucky enough to be a principal investigator in one of the first hepatitis C studies with Gilead Pharmaceuticals. And the medication worked 100% of the time. People went into remission. But I literally can't think of any other trial that I participated in.
That would be certainly one of the more recent ones, yes.
Yeah, so although remission would be great, very often if someone's not functioning, and you can return 20% of their abilities and 20-30% improvement, and that will make the difference between them being in bed all day versus getting up and going to work. That's something very meaningful. So although I'd love to get people into full remission, it doesn't have to be the goal. You know, again, it's a continuum. It's a step in that in the right direction.
We're headed towards that. Yeah,
we're headed towards that, right?
Yeah. So now, a substantial proportion of patients on that journey certainly receive many combinations of medications. How is polypharmacy helpful, specifically with mental health disorders?
So polypharmacy literally means that someone gets more than one medication or more than one treatment, and it's looked on as something very negative. It can be positive or negative. You know, certainly if you have an elderly person in a nursing home and you have 5 doctors involved in their care and nobody's looking at what the other doctor is doing, and they end up on multiple medications all doing the same thing, that's a recipe for disaster, and the side effects could be life-threatening. Mm-hmm. But it's what I like to call rational polypharmacy. So this is especially true in psychiatry. So suppose I'm treating somebody for depression, and I put somebody on a serotonin reuptake blocker, inhibitor, and they have a partial response. So I want to take advantage of that response and not stop the medication, but I want to possibly move them along to that remission goal. So then I may add a second antidepressant, but I pick something that works on a different set of systems in the brain, different neurotransmitters. So I might pick something that works on norepinephrine. So now I'm hitting norepinephrine and serotonin. Now maybe I still just get a partial response. I may end up using a third agent that works on dopamine. So now I'm hitting serotonin, norepinephrine, and dopamine. So I'm taking a rational approach. I'm trying to hit several different systems in the brain, hoping that one or all of them will result in a person's improvement.
At the onset of our conversation, you mentioned many of the areas that you're working in with regards to some of these mental health disorders, as well as CNS. What are the diseases you're currently researching, maybe without mentioning the actual treatment, and where can people go to find out more information, whether our listeners are a potential subject for a research initiative, or perhaps there's a physician or a caregiver in our audience that is looking to recommend people to get more information about the research?
So my company, ERG, we do studies in all aspects of mental health disorders, including schizophrenia, both acute, chronic. We do inpatient studies, all phases, from phase 1 through phase 4. Early phases are when a compound is really being looked at more for safety purposes than efficacy. So we're involved in all phases. Bipolar disorder, also referred to as manic depression, both mania, where people have too much energy and do things that are very impulsive, or they can be bipolar and be depressed or cycle between the two moods. We also do research in major depression very frequently. We research anxiety disorders, including post-traumatic stress disorder, which we haven't touched on yet. But that's something that is very timely. A lot of people are experiencing PTSD symptoms right now.
Very much so.
As a result of the pandemic, especially if someone has experienced prior traumas, but even people that haven't. Right. So we do studies on that. Generalized anxiety disorder, ADHD, you name it, we do it. Substance abuse disorders, we do a lot of work with that. That's critical, especially now, because we're seeing a huge spike in the use of illicit substances for people who try to cope with the stress of what they're experiencing currently. So that's an important area to focus on as well. We also do studies with children, adolescents, as well as adults.
Wow.
And we have a website that goes over all of our sites, and it describes the different studies that we're doing. There are other companies, of course, that do clinical trials. The government has a website called clinicaltrials.gov, which lists virtually every study going on in the United States. It's very comprehensive. You can find anything on that website, and it will list where the study is being done and who the investigator is and how to contact them.
Great, great. Now, you and your colleagues have also been involved in some treatment studies as well for COVID-19, correct?
Absolutely. We're very involved in COVID-19, both in terms of vaccine studies, treatment studies, as well as prevention studies. We're even involved in an epidemiology study to look at prevalence rates of COVID-19. So we're extremely involved, and we want to be even more involved in this. We really want to be leaders in this area, and I think we're emerging as such.
Well, thank you for that. Certainly, it's timely, relevant, and especially on the epidemiological side, something that we all want to really begin to understand a lot more. Something that you and your colleagues have also been extremely proactive about in your approach to the management of the COVID-19 pandemic is to continue to ensure the safety of those study subjects, your staff, as well as others that have been involved in the execution of these clinical trials. What has been your response to mitigate current risks?
So I won't discuss testing right now. Let's put that aside. So besides testing for the virus, we have a very comprehensive mitigation strategy. We thoroughly evaluate potential subjects. We question them on the phone about whether or not they've had any exposure or they're at risk for exposure, and if they have symptoms. There are questionnaires that they're put through. If we suspect that anyone has been exposed or that has it, well, we think they have it, we'll refer them for appropriate treatment. Okay. But if we suspect exposure, we won't even bring them into the site because we don't want to risk our staff being exposed, of course, and we want to do what's best for the potential subject as well as our own staff. Then when we do bring subjects in, we check their temperature. One of the main symptoms is elevated temperature. 100.4 degrees Fahrenheit seems to be the cutoff. Anything above that puts you at risk for having the virus. We make sure we use PPE, protective equipment, and we keep stocked in that. So all of our staff, and we ask our subjects to do this as well, they wear masks and gloves. We sanitize everything very carefully. We do very deep cleansing of the sites, and we do that in between visits as well. And when we do inpatient studies, we make sure that we do social distancing even in a clinical trial. We'll do that outpatient as well. So we'll try to keep our subjects 6 feet or more apart. We'll do smaller cohorts than we're accustomed to doing to ensure that we're able to put that into practice. And we make sure that our staff treats everyone like they're COVID-19 positive. Sort of like universal precautions with what we do in general in medicine with blood, we're doing the same thing in response to COVID-19.
No, and that's incredibly admirable. I know that you have sites throughout the country, and certainly some of those sites have been able to pivot also to working in a remote environment. Can you share a little bit about how you're currently facilitating ongoing trials with the use of some of these virtual visits?
Yeah, I'm certainly glad you asked that. So there is a push to do as little as possible in person for obvious reasons. So we're trying to do as much virtually as possible, avoiding people actually coming into the clinic. So we already had the technology, which we're working on improving and instituting. So we're trying to do visits at home as much as possible, even monitors from our partners that come in to look at the status of a study. We try to do that virtually, and we make the records available to them, and we speak to them via Zoom or by phone. We try to avoid them coming into the site. If they insist on coming to the site, we'll evaluate them, see where they've traveled to, and determine whether or not we feel it's safe for them to enter the site. We'll put them through questionnaires, take their temperature when they come in as well. And the safety of our subject is of the utmost importance. So, we're very sensitive to keeping them safe. So a lot of these strategies are for the sake of the subjects, and treating them as much at home as possible is really in their best interest as well. And I think we're going to see more of a push for that to happen as time goes on. I don't think anything is ever going to be the same, and the way we conduct clinical trials in this country is going to change as well.
Absolutely.
And it may have happened anyway.
No, I appreciate and applaud the efforts of you and your colleagues in terms of being nimble and adaptive in this process. Certainly, to have already been engaged in many of these technologies, and to be able to pivot to now having site-specific plans where you can enact that as your standard operating procedure is just magnificent. I did want to pull back on this and get your view from a physician standpoint. Certainly, you've seen the progress that's been made in terms of telemedicine, remote visits, both phone and video, remote pre-screening and consenting that we've talked about. But then there's also the home healthcare and home visits that really run the gamut of all the different ways that we can engage patients, both with regards to patient care as well as their participation in a clinical research initiative. What are your just broad thoughts on all of these technologies, all of these changes, and if they're for the better?
As I said, I think that we were heading in that direction anyway. So I think this has only served to push that forward. But there's also
a little bit of acceleration along the way. It's like riding that bike downhill, right?
A lot of acceleration, but there are also some challenges. We were awarded a COVID-19 treatment study, and originally the goal was to do everything virtually, but we have to do cardiograms. So it's interesting because
the iPhones haven't allowed that yet.
Hey, my Apple Watch, I can do a rhythm strip on myself, but it's not a 12-lead EKG.
No,
so
not yet. Not yet.
Not yet. We'll be there. We'll get there. I'm still amazed that I can even do a rhythm strip with my watch.
Yeah.
And I do it. So, but there's a lot that we can do virtually and that we are doing. And my company has an excellent IT department and a very talented director, Dave Hennessy, and we're really working very hard in that regard. And we're on the cutting edge of that technology.
No, absolutely. And I think staying ahead is going to be key, not only for competitive differentiation, but also to be able to really understand what standard of care is going to evolve to before you get there. So I think staying ahead of the curve is critically important for any organization. For those of you that are participating in clinical research, certainly you'll be there before some of those practices will be. So I think that is just an incredible way to proceed, and to be so open-minded to adopt and be an early adopter in so many of those technologies. Certainly positions ERG very, very well to handle whatever clinical trial they are asked to participate in going forward. It's so incredible.
It's estimated 10% of medical practices have already shut down permanently. Yeah. And I suspect that number is going to grow. So telemedicine is critically important right now, and the system is overloaded.
No, absolutely. And we certainly know that many research studies, as well as some sites across the U.S. and across the globe, have had to shut down because of financial issues. But certainly we wish all these individuals, all these subjects, and certainly these trials to continue and to see their completion, because certainly we are counting on so many of the results as we face whatever comes next. And certainly in terms of these evolutionary treatments and these revolutionary treatments, we're certainly looking forward to what these breakthroughs may be, but we certainly need the sites online. We need people to be able to staff them, and certainly we need new ways of engaging, and it sounds like your organization is certainly there.
Thank you. Mario, if you'd allow me, I started to touch on something that I think is very important to discuss, yeah. And that is actual testing for COVID-19.
Let's talk about that.
Clinical trials.
I can only imagine how that's complicating some of your procedures.
You can't imagine. Yeah. I spend hours every day having meetings about this. Yeah. So I will say I'm not an infectious disease specialist. I'm not a virologist, but I'm a scientist, and I spend roughly 5 to 10 hours daily reading up on COVID-19 and testing and treatments. And the more I read, the more I don't know. But I think I probably have as good a handle on it as any non-specialist in that area.
Yeah, let's talk.
So,
yeah, please.
Sure, yeah. So first of all, for the sake of everybody listening, this is a very confusing area. So let's describe the different testing that's available right now. So the test that actually detects genetic material in the virus, it's actually RNA, is called a molecular PCR test. That will tell you whether someone has an active infection right now. There's another test that is an antibody test. Theoretically, at least, when someone's been infected and they recover, the hope is that they build up antibodies in their blood that then perhaps will make them immune to being infected again. So the way to determine that is to measure antibodies in their blood. They're called IgG and IgM. However, if you do an antibody test, it will just tell you if someone's been exposed. It doesn't tell you if someone has active disease.
Right.
So you might say, well, just do both. Well, the problem with that is the PCR tests are accurate. And there's 7 rapid tests on the market right now. Cleveland Clinic did a very nice study, and 5 of them came out very nicely. They detected the virus in over 95% of the time. That is not the case with antibody tests. In fact, the FDA and the World Health Organization issued a warning that the antibody tests are not accurate. There's over 100 that exist. Some of them have emergency FDA authorization. It's called EUA, Emergency Use Authorization. It's a down and dirty way for the FDA to get things onto the market, but it's not their usual comprehensive review. And some of the FDA approvals for antibody tests are only for research use, and they're not meant to be used clinically. So my feeling, and most of our partners agree, and the experts agree, that you're better off not doing antibody testing right now unless you're doing some kind of epidemiological study and you want to look at who's already been infected and you want to do projections. But if you're looking for active disease and you want to use something accurate, the PCR test is the test of choice. So at least twice a day, I'll have meetings with partners related to either restarting a study that's been on hold or starting a new study and being asked what we're doing for testing. And the interesting thing is, rarely do they come to us saying, this is what we want you to do. They don't know. So,
Interesting. So they're not issuing the mandate. This is now a conversation that you're initiating.
I'm talking about non-COVID-19 studies.
Right.
COVID-19 studies, obviously, you have to test for
Absolutely,
the virus.
yeah.
Yeah. So I would say 90% of the time,
Wow.
they come to us asking what we want to do, but they don't really have a plan. Now, our feeling, and we have researched this extensively, is that you don't blindly test for the virus.
Okay.
First of all, testing is still not as available as it should be. So do I want to waste the test on somebody asymptomatic and take it away from somebody symptomatic that desperately needs the test? I'd rather not if I don't have to.
Right.
But here's the main point. If somebody is entering a clinical trial, non-COVID-19 trial, and I test them at screen and they test negative, if I don't confine them to our site from then on for the rest of the study, I don't know what they're going to do. I can tell them to confine themselves to their home, but I can't control that. So they could be exposed the next day and then test positive 2 days later.
Right.
So that test to screen really doesn't have a lot of value.
Right.
Now,
and then what does it mean then in terms of taking action when they do test positive if you test them again?
Not much. I mean, it actually does not provide useful information. Now, there are situations where we should test. For example, special populations, elderly, people with severe kidney and liver problems, they should be tested. But what we do then is we confine them to our unit, and we control their comings and goings, and we are likely to test them again right before they randomize. That's when they actually get study medication.
Right.
So that makes sense. So we're trying to take a rational approach to this. We don't want to just blindly come up with a plan that we're going to test everybody. We want to test people that it makes sense to test in, and we don't want to just waste tests that are unnecessary and won't have any meaning.
Well, I think that may be a prescription that we need for America as well. So I think those are notable quotables from Dr. Gruener. Let's test where it makes sense, and we don't have to test everybody, and we certainly don't know what it means.
Mario, I don't want to be political at all,
Yeah.
and I support social distancing and all the mitigation strategies to try to prevent transmission of the virus. But I always find it interesting when a politician gives a strategy that may be unpopular, and they say, "Hey, I'm following the science. Don't blame me. I follow the science." I don't know what that means.
Right.
I mean, I'm a scientist, and I don't know what science to follow.
Right.
You're
reading about it daily.
Yeah, I mean, you mentioned evidence-based medicine, so I try to gather as much evidence as possible, combine it with our past experience, and then clinical judgment, and come up with a plan.
The one consistent phrase that I have heard from many of your colleagues that I've had the opportunity to interview, and both on the Stealth for Health program as well as casually talking with colleagues around the globe, is that we are consistently inconsistent, both in testing as well as in our protocols. And I think you are doing a wealth of good engaging in those conversations with your partners, because like you said, 90% of the time when you're having the conversation with them about continuing or restarting some of these trials, we need to be educated and we need to be providing value, and certainly you're providing the value into what we should do, as well as what we may not be needing to do, may be unnecessary. And I think these are certainly good principles for us in terms of next steps. Certainly as a healthcare ecosystem, but also on the larger scale of the United States. I think some of the things that I've heard, again, not getting too political, talking about the science, wanting to be data driven, and then wait 5 minutes and that'll change. But I think there are certainly sound reasons why we need to take certain steps with regards to testing. And it's certainly not for everyone. We don't need a test for everyone every single day. And I think certainly cooler heads will prevail, and good science will prevail. But we know from the work that has been done historically that there certainly isn't a need to test absolutely everyone, and certainly not every test is equal. So let's kind of tie a bow around that. But certainly as we get better sensitivity, better reliability on some of these tests, if that is even in our future, certainly that's something that we can begin to talk about a bit more. Certainly with 100 tests available, I think even then it could be very, very confusing as to which one and why. So very thankful for those like Cleveland Clinic that are assessing some of those tests. I'd like to switch gears and in the time we have remaining, talk a bit about you. And I typically do this at the onset of every discussion with individuals I interview, but I thought it was important due to Mental Health Awareness Month that we talk about raising awareness about that first, and certainly for individuals that are looking for more information on that, we've guided you to a number of resources, but we'll say it again here. The NAMI website, NAMI, is certainly chock full of resources, as well as information where you could read more about screening, clinicaltrials.gov, as Dr. Gruener mentioned, listing many of the, if not all of the clinical trials that are ongoing with regards to mental health disorders. But I do want to talk about you and your inspiration in the time we have remaining, certainly some of the influences that put you on your pursuit of a career in medicine that has been your life's journey. Dr. Gruener, what has been your earliest recollection of medicine?
It's the only thing I ever wanted to do. And my inspiration was my maternal grandfather. So both my parents were Holocaust survivors. They both survived the war in Poland. And my mother was in a ghetto in a town called Lemberg, also known as Lvov, which is now part of the Ukraine. but it was under Poland back then. And if not for my grandfather, she wouldn't have survived. He was a very resourceful man, and the Nazis were rounding up children, and they were in an apartment in the ghetto, and he figured out a way to create a false wall, and he hit her effectively twice when they were rounding up kids to kill. And he had a factory before the war that was very successful, and the Nazis kept it going, and they wanted him to continue working in it. So he had a special permit. He actually wore a tag that said "Very Important Jew," which allowed him to exit and re-enter the town. And he put my mother under his coat one day, and he snuck her out of the ghetto, and he was very popular amongst his employees, and some of his employees agreed to hide her, and they hid her in a box where she stayed for about a year. She actually lost the ability to walk and to see and to hear, which slowly came back. But if not for him, not for my grandfather, I wouldn't be here. And I remember being very young, 2 years old, and I was very close to him, and I wanted him to live forever. So I thought, I want to become a doctor so I can come up with a plan to make that happen. And that was my inspiration for going into medicine as early as I can remember.
Any other individuals along your journey? Any mentors?
Certainly, I had personal doctors that I was very impressed with that inspired me to go into medicine. You know, my family doctor, I used to look forward to going to the doctor. Most kids wouldn't. You know, they were terrified.
Well. It was an adventure. It was an adventure to see what was going to happen.
Yeah, I loved it. So, you know, that just solidified for me that this is what I wanted to do. I used to read books about medicine, and I remember reading a book, The Making of a Surgeon, for a while. I was determined to be a surgeon. That obviously never happened. So, and I have no regrets, but you know, it's not an easy life. It's not for everyone.
No, and certainly you have shared with me personally the stories of your parents, you know, both of whom are Holocaust survivors. My own grandfather was as well. And, you know, I want you to also tell us a little bit about your father, his life story, his book, and certainly his legacy.
So my father, Jack Gruener, also grew up in Poland. He was in the town of Krakow. And when he was 13, his parents went out to run an errand, and they never came back. So he never found out what happened to them. He spent his life trying to find out what had happened. He knew they were killed, but he didn't know how. So he was on his own from then on. And he ended up being sent to a number of concentration camps. He ended up being in 13 camps, including Auschwitz, where he had a tattoo placed on his arm. That's actually the title of the book about his experiences. It's called Prisoner B3087. That was the number on his arm. He was liberated by the U.S. from Dachau. He was in the camp that was portrayed in Schindler's List, that my great uncle was killed by the commandant of that camp. He survived death marches. It's just a miracle that he lived. And Scholastic actually published a fictionalized account of his experiences, but everything actually happened. They fictionalized some of the relationships, but all the events were 100% true and accurate. And the book is a bestseller. It's mandatory reading in schools all over the world, and it's been translated into several languages. There's an audio digest version of the book. It's really inspiring. Obviously, I'm biased, but I highly recommend it. And interestingly, my mother wrote a book as well called Destined to Live.
Yeah, so let's talk about your mother, because she is still with us, and she not only has a book that she's written, but she's actually writing another book. There's a new pursuit underway for Mom. Tell us a little bit about this.
Yeah, so it's a miracle that my mother convinced a publisher to not only publish her story, but also publish my father's. And like striking a third time, they actually allowed her to write a third book that describes how she returned. She called it Back to Life. I believe the publisher is changing it to something that's more catchy. But it's about how she returned to the living, so to speak, and her experiences when she came to the U.S. and that should be out in a few months.
Wow. Now,
But what's
please.
so what I think you were going to ask? What's interesting about her? It's my father was very stoic. He passed away from Alzheimer's about 3 years ago, but he didn't like to talk about the Holocaust, and he seemed to manage his stress very well. My mother always talked about it. I grew up listening to stories on a daily basis, and without question, she has post-traumatic stress disorder. And what's both sad and interesting is that the pandemic is making it worse. She sees parallels to what happened to her in Poland in that time period in connection with what's happening now. And if you think about it, I mean, the government is intervening, appropriately so, but they're telling us what to do, where we can and can't go. They're isolating us. There's some perception that our rights are being interfered with. And she's having flashbacks. She has nightmares every day. And I did some research on this, and apparently it's not uncommon in this time period amongst Holocaust survivors.
Wow.
So it's something.
Mom is currently 96, correct?
My mom is, she would kill me. She doesn't like to discuss her age. She's much younger than 96. But let's just say she's over 75. and much
She's eligible for Social Security. Yeah.
Correct.
Yes, I like that. That's safer for both of us.
Right.
But certainly these are amazing stories, and certainly the fact that she's still with us is truly a miracle, considering everything that she has endured, both in her childhood and certainly I'm so happy that she was able to express these stories to you, and certainly the legacy that you are for both your parents and your maternal grandfather, being able to share these. Certainly, I'm going to look forward to reading both of their books and your mother's upcoming book. Certainly looking forward to seeing the parallel journeys to that of my own grandfather, who was also liberated from Dachau by the Americans. But certainly the impact of the current quarantine and the PTSD issues of the social distancing, the isolation. We know that not only at this time, but for older adults that are in isolation, we know the detrimental effects on their mental health, and we know how life-shortening some of those isolations can be. The fact that your mom has certainly beat all those odds and continues to be with us, we certainly wish her a much long and healthy life, and certainly look forward to hearing of her great success with her upcoming book. As our time for this episode is drawing near, Dr. Gruener, let's help some people that are watching. Let's give them some tangible ways that they can improve their own outlook if they are suffering from PTSD, if they're feeling anxious, if they're feeling mildly depressed because of their current situation. Certainly many people are currently overwhelmed. We're all struggling to keep our families healthy and virus-free. Certainly in the absence of our ability to practice our religions where we would naturally go to be together and to think and pray together about what we're currently enduring. We're needing to do that at a distance, and certainly in our own homes. We can't gather together like we normally would. So this concept of social distancing really certainly poses a unique challenge for us, and certainly there's very few of us who have experienced this in our lifetime. What can we all do to personally to manage, as well as to help others manage with this? And I know this has been termed into a phrase called acute chronic uncertainty. I don't think that's a medical term, but any advice on how we could all manage through this a little bit better?
Maybe it should be a medical term, and I actually do have some suggestions. First of all, do not spend 16 hours a day watching the news. There's a lot of misinformation. There's some good information, but there's no benefit to obsessing about this. Don't wake up and turn on the news as the first event of the day. Do something for yourself. Don't be on your phone all day, looking at information about the pandemic. You don't have to isolate. You can practice social isolation, but still have contact with people. And I think the myth is people think that the more contacts they have, the better. You know, if they have a party on Zoom with 50 acquaintances, well, they're really doing a wonderful thing, and they're showing how social they're being. I actually think that can do more harm than good, because they're not real relationships. So typically people have 4 or 5 intimate relationships. Our spouse, our children, especially if they're adults, siblings, and most of us really have 1 or 2 good friends. So my advice would be to spend a lot of time with your close contacts, but you don't have to obsess about just racking up, more contact hours every day that really don't have a lot of meaning. That can actually be more isolating than anything. And there is uncertainty, but we're going to get through this. We've been through horrible things. We talked about the Holocaust. I mean, if my family could survive that, we can get
as
through
children.
anything.
Yeah, as children, they
Exactly.
survived.
Yes, as children. Yes, my mother was a young girl, and my father was just entering his teenage years.
Wow.
So we are going to get through this. There's reason to be hopeful. We're going to come out with effective treatments, hopefully a vaccine shortly. So there's uncertainty, but there's reason to be hopeful. And I know people are really tired. They have isolation fatigue. And there's a lot of protests going on. I read something very disturbing yesterday, that there's been a spike in gun sales. I'm not going to comment about people's rights to bear arms, but when I hear about people that have never held a gun before, suddenly getting 2 weapons, it makes me nervous. So, it's fine to protest, but do it non-violently, and express your opinions, but do it while following the rules.
Agree. No, I think this is definitely sage advice. Let me open up the floor to you for the final word.
You asked me my motivation for being a doctor. I don't want to leave this out, but my wife and I have been together for a long time, and my job requires a lot of travel. And ironically, I feel very fortunate that she and I have had the chance to sort of reconnect and spend a lot of time together. And she actually helped put me through medical school. So she was also a great inspiration to me. And interestingly, we're not getting on each other's nerves. We're actually getting along better than ever. So, I mean, there's an example how, concentrating on intimate relationships can really be the best strategy.
More dinners together than ever before?
We have dinner every night together in
Amazing.
front of each other. It's wonderful. And we have regular Zoom sessions with my children, who are both in Texas, in a little bit of a safer environment. We're in a suburb of Philadelphia, which is a major hotspot.
Very much so. Very much so. Well, we wish you and your wife certainly continued successful evenings together, spending good quality time together. That I think is the silver lining in all of this. I have 2 what I affectionately call refugee college students that have been home with us. We've had more dinners together with them and my wife than we ever have before. To your mom, we wish her great success in her upcoming book, and certainly I'll look forward to reading both your mother and father's book, and I will wish you and certainly your colleagues at ERG just great clinical success with all the research that you're doing, on all the research you're about to embark on, and really the incredible progress that you're making in terms of the clinical trial process, and really being so innovative in what you are doing every single day. Certainly being prepared and engaging and adopting so many of these technologies before they were cool and before they were absolutely desperately needed. These pivots that you have made have just been absolutely amazing. So, Dr. Gruener, I thank you for your time, your participation. Certainly look forward to our next conversation, and we look forward to welcoming you back, whatever that new normal may be, and we'll certainly talk a little bit more about what some of those epidemiological studies look like, and certainly some of the results, and analyzing what may be coming next. So for the New Right Network, I'm Mario Nasinovich. To access this episode and other on-demand programming from Stealth on Health, I invite you all to visit newrightnetwork.com, the right voice right now. Thank you for tuning in. Please stay informed, and please stay healthy. Welcome to the Healthcare Voice of the New Right Network. This is Del Darnell with Mario Nasinovich.